We need to ask everyone who subscribes to the show, please listen to the podcast when it drops and give us a little discussion about it. It really helps. Also, we want to thank our sponsor, Hydrolite. Go to the banner on drdrew.com for details. If you click on the drdrew.com Hydrolite banner, we have a 30% discount for those particular vendors on the Amazon site. Also, a thanks goes out to alliant.edu for those support. A great program, great school. Check them out if you're thinking about training in psychology or you're looking for care. Great place to go. I'll tell you more during the break. Support our sponsors so we can bring you more weekly infusions.
Welcome to Weekly Infusion with Dr. Drew Pinsky and Dr. Bruce Heischober. Weekly Infusion addresses medically related topics. It's in the know, entertaining, and everything you want to know about health and medicine. Now may I present to you the very wonderful Dr. Drew and Dr. Bruce.
Hey everybody, welcome to the Weekly Infusion. Bruce, how are you, sir?
More and more exciting.
Yeah, we just get such great guests.
Wow.
It's lovely to sit and chat with our peers for a change. I don't get to do that enough. Not just our peers, but our peers that are doing exceptional things.
Yes.
So today we have Dr. Omid Hamid. He is the director of the Melanoma Center. He is Phase 1 Immuno-Oncology program at the Angeles Clinic and Research Institute. At Angeles, ANGELS Clinic is where you can find him, or theangelusclinic.org. Dr. Hamid, thank you so much.
Thanks so much for the invite. It's a pleasure.
So there's a lot to get into here. I mean, immunotherapies, genomic medicine, personalized medicine. You know, Bruce and I were talking recently about how much this is exploding. I mean, this is such an exciting time for this. And in an interesting way, melanoma has been at the cutting edge of this explosion.
Oh, yes, I would agree. I would say that nowadays when I give a talk on melanoma, I have to put the disclaimer that this is not a melanoma-centric talk. All of the breakthroughs that have come through targeted therapeutics and immuno-oncology and melanoma are now generalizable to multiple solid tumors, including lung cancer, kidney cancer, bladder cancer, being used for breast cancer. Breakthroughs in immunotherapy for melanoma have led to paradigm-shifting therapies for Hodgkin's disease and lymphoma.
And I've been working with
all-inclusive.
And I've been working with the Prostate Cancer Foundation, and they're big in immunotherapies, and some of that is feeding back over again to melanoma. It goes out to us and then back again to melanoma.
So if I were a non-medical person, I would ask the question, is this what people have looked at as being the ultimate cure for cancer? Do you see it coming from this avenue? Or is that a too dumb question?
I would say to you that it is the beginnings of an understanding of how to unlock our own bodies to control and eradicate cancer.
I saw a case. I didn't see it. I just missed seeing it, but I was on an oncology ward, and everyone was buzzing about the fact that they had a patient that came in with a metastatic melanoma. This is 40 years ago, 35 years ago.
Wow.
Who spontaneously resolved. Like, spontaneously, it all just went away. And I thought to myself, well, that's the immune system. That's the immune system. And at the time, or just on the heels of that, some of the vaccine therapies became popular in melanoma. Is that yielding any results?
Yes. So what you saw there is something that we've seen infrequently, which is a resolution of a melanoma or any solid tumor with either through an infectious insult or through something that stimulates the immune system. We've seen this. We have patients who show up with metastatic melanoma, and there's never been a primary diagnosed, and it's because the body took care of the primary and one cell got away. But that is the immune system working to eradicate cancer. We've known this for over 100 years with Coley's toxin, and the fact that certain malignancies resolve post-viral infections, and similar instances there. We've also, for a long time, looked at vaccines as an initial avenue to targeting cancer. And while we haven't had major breakthroughs there, at this point we've done phenomenal work on vaccines, and they're making a comeback. In fact, some of these neoantigen-specific vaccines that are now being produced based on a patient's tumor, and neoantigens, which are specific proteins that the immune system recognizes as foreign that are encoded by those cancer cells. We have the ability to now make vaccines that mimic those neoantigens that are specific for each patient and each cancer. And those are coming in as adjuncts to our now new immune therapeutics, our PD-1 antibodies, or anti-CTLA-4 antibodies that have been approved for multiple solid tumors.
I had vaccine on my mind because we had spoken to Dr. Henry Friedman, who is using it with modified rhinovirus to treat glioblastoma with tremendous result. But let's go into the immunotherapies. Do you say PD-1 receptors or CD1 receptors?
PD-1, programmed Death-1 antibodies.
Okay.
That target PD-1 and its ligand, ligand 1. So these are, if you would think of it as a way of a cloaking mechanism that the tumors use. And it's normal. In our bodies, we have ways of cloaking normal cells from the immune system so that we don't have autoimmune disease or that we don't get inflammatory symptoms in places that we don't want it. Well, these tumors have found ways to upregulate those things, and one of those is PD-L1, programmed Death Ligand 1. And they upregulate that, and then when our immune cells, those killer T cells, come to attack this tumor, that PD-L1 interacts with PD-1 found on those T cells, and that shuts off the immune system. And what we've found is that we can make antibodies which go and block that interaction and allow the T cell to remain active.
Hang on a second. I'm going to break it down for people again. So T cells, again, are lymphocytes. These are the immune cells that go and attack viruses, foreign cells, foreign bodies, whatever it might be. And the PD-L1 is something on the surface of cells that tell the immune system, this is part of me, this isn't a foreign body. And the PD-1 is on the T cells and then interacts with the PD-L1, is it not, if I remember right?
That's right, exactly.
And that interaction or those particular receptors can
shut it off.
Shut off.
The whole thing.
Yeah, it can be shut off in just tumor cells. That's the trick. If you shut it off in the whole body, your T cells will attack your whole body then.
Fascinating.
Right.
So go ahead.
We've been able to utilize this, and just by treating with just one drug that blocks this negative interaction. And in melanoma, which is where it was first looked at, we're seeing remarkable regressions in tumor control for years. And similar drugs like this, I have patients who have been either controlled or with no evidence of tumor for years and coming over a decade.
When the melanoma does manage to work its way around that treatment, is it just because it's done as much as it can and then it stops working and the tumors start growing again? Or has the tumor found a strategy around what it is we're doing?
It's more what we found to be the latter, that we're finding that the tumor finds other immunosuppressive things, other immunosuppressive ways, whether it be upregulating another mechanism or things in the microenvironment around the tumor that they suppress the T cells.
So how many drugs are there that block that interaction that you're using for melanoma right now? The PD-1?
There are multiple. The PD-1, PD-L1s, there are multiple. There are about 3 or 4 main ones that are in clinical trials in the United States. But where there are other checkpoints, is what we call them. There are other checkpoints on the T cells.
Checkpoint inhibitors.
That we are beginning to...
Right.
There are checkpoint inhibitors and checkpoint stimulators.
Stimulators.
There's checkpoints that are like agonists that stimulate the T cell, and then there are checkpoints that are inhibitors that inhibit the T cell. So what we've been doing is identifying those and making antibodies so that we inhibit the inhibitors or stimulate the agonists.
Is anyone doing these kinds of treatments at initial diagnosis before metastatic disease if the melanoma is of a certain depth?
Oh, absolutely fantastic and very timely question. The way that therapeutics work in any solid tumors, we find something that works in the metastatic setting, and that's the time where the tumor's left the local environment, and I usually say it's left Brooklyn and gone to Manhattan and Bronx, left and gone, disseminate through the body. And when we find that it works and it gives survival advantage, that's a holy grail, we bring it to earlier times. We bring it to the adjuvant setting. The adjuvant setting is a setting where we've diagnosed the tumor and we've eradicated it locally, but there's a high risk to come back. And through clinical trials at our center and others like ours, we've taken these PD-1 inhibitors and looked at them. And more recently, the publication in the New England Journal of Medicine showed in high-risk melanomas, that's stage 3, that's melanomas with lymph nodal involvement, giving these drugs earlier has led to improved relapse-free survival, improvements in allowing greater time without the tumor coming back and greater time of survival. So, yes, they're being moved into earlier and earlier, and then we'll be initiating trials looking at those higher-risk melanomas that have not spread to lymph nodes and are looking to bring those to the earlier arena.
That is absolutely what I would want. If I had even a 3 millimeter melanoma, I would want the CD1 receptor inhibitors. But how long do you take them for? Is that an indefinite kind of treatment, or can you answer that yet?
Well, we're coming to some of those answers. So it's about 5 or 6 years since the major trials in melanoma have begun, and we're starting to look at patients who did really well and all their tumor went away, and then we stopped giving them the drugs and have started looking at how they do. What we know is that these drugs can work on the immune system almost like vaccination, so that if we stop and those tumors return, we can reinitiate giving these drugs, and we've seen control and regression of tumors. So at this point, more recently, as investigators with these drugs, we've presented data of patients who have stopped getting them. We have about a 10 months to 1 year follow-up and have seen greater than 95% of those patients continue to have control of their melanoma. And that's what you would expect. These drugs are not given like traditional chemotherapeutics where they have to be in your body like weed killers. They stimulate and they educate your immune system, almost like having a police force at all times in your body looking for these tumors and eradicating them. They utilize your immune system.
So you're almost healthier while you're getting the treatment.
Well, except there are side effects of the drugs, right?
Oh, great transition again. Yeah. The side effects from these.
Yeah. Yeah.
These side effects are the next portion of education where physicians such as myself who have the expertise are going out in the community and educating our colleagues on how to understand and how to treat these side effects. Where the majority are mild and are controllable, there are some that can be significant and life-threatening. You have time to identify these and treat them. We have therapies, and they're very easy once you identify to control them. But you can see that if you get an unwanted immune response in your colon, you can get colitis, which can cause significant diarrhea, dehydration, and side effects to other organs in your body. We've also seen inflammatory syndromes that cause the pituitary gland not to work. So you don't get the hormones that you need. So you can't mount an adequate stress response to an infection, or your thyroid is not working. So the patients are fatigued and confused. The testosterone level goes down. So the strength and the muscle mass in the patients go down.
So you get an autoimmune panhypopituitarism?
That's right, an autoimmune panhypopituitarism.
But wow. You're not predisposed to other malignancies, as with some of the other prior treatments for cancer.
No, we haven't found anything that is linked to a risk of a secondary malignancy. But some of these side effects can be misdiagnosed or underdiagnosed. Even if it's less than 1%, we've seen inflammation in heart muscle that can lead to heart attack. We've seen neurological complications such as Guillain-Barré. Now, when we mention these things, a big, huge red flag goes up, and I really want to step back and say that the incidence of these side effects is low. They're very manageable, and in no way am I saying that we should not be offering these therapies to patients. In fact, I'm saying the opposite.
Yeah, I hear you. And they all sound like things that are very manageable. You said, though, heart attack, not cardiomyopathy?
It's almost like a cardiomyocytis. It's a muscle inflammation.
Myositis. Yeah.
But it presents with a troponin elevation, and so most people feel like they're having a heart attack from the main way people have heart attack from a arterial blockage, but that's not the case. And what happens now is it's more important because we're taking these immune drugs, and as we have more and more of them, we're combining them. We're finding that their efficacy can be greater in combination.
Did Jimmy Carter have a combo? Is that what I heard?
Jimmy Carter had a drug that's very near and dear to my heart. It's called pembrolizumab, and we were part of the initial trials there. He had it, as far as I know, as a single agent. He had it at Emory with a wonderful guy, David Lawson. But he also did have radiation along with that, as I've heard. And he also had surgery. So the whole immunotherapeutic paradigm is not excluding other manipulations that we have. We've learned that radiation can stimulate immune response by releasing tumor antigen, and that's a huge tool in our armamentarium to focally radiate an area in order to augment the immune response. We've also now found a greater need for surgical oncologists, not to do huge surgeries, but in order to allow us to continue with our therapies. If there's a symptomatic lesion, or if there's a lesion that is not allowing us to move forward with therapy, they can resect those. So it's just a functional resection of a single metastasis. And also surgeons are extremely important to a new field in immunotherapy, which is adoptive T-cell therapy. And I'm sure you've heard about that from Steve Rosenberg at the NCI and other sites, where we take tumor cells out and we tease out of them those T cells, those killer T cells, and we grow them in a lab up to 50 to 100 billion cells, and then reinfuse them into a patient.
It's very exciting.
Is that melanoma specific, or is that?
Actually, it began in melanoma, but it's moving on to other solid tumors.
You don't need it. Killer T cells get everything.
Right. I was just wondering which. So
we just have to find the right way to focus them on the right thing to attack.
I have another question. I'm asking you because of the nature of the immune system. But I had a friend that had some sort of experimental melanoma treatment at Duke in the early mid-'90s. Was supposedly disease-free for, I think, 15 years. And then around 2010 had a recurrence. And I know he passed away within a couple of years, but he ended up going to Korea for some sort of a bone marrow thing. But anyway, what's the in these long disease-free periods? Is there some interaction between the immune system and remaining cells, or could be a second, just another sporadic melanoma creeping up, or where am I asking?
Is it keeping it under control? Yeah, I guess I'm not answering.
Is it a cell sitting there that's dormant? Can cancer cells become dormant, or is?
Yeah. So there's multiple ideas here. So probably what you're talking about is high-dose interleukin-2, which was a standard and remains a therapy for metastatic melanoma. And we have patients who have achieved a complete response and have lived over 30 years from their diagnosis of metastatic melanoma. Now, when there's a recurrence, it could be, patients with melanoma have a secondary risk of another melanoma, but it could be one cell picking up a mutation or a change, and then seeing that happen, absolutely seeing that happen, and then you can come back with the same therapy and see if it works or move on to other therapies. But it can, and sometimes has happened. Historically, when we have spoken of patients who have had disseminated tumors and have achieved a long-term survival from even receiving chemotherapy, that was based on the idea that we have reduced that tumor mass so much, just to the point where the immune system can get over that hump and control those tumors. So the immune system idea has been there for decades.
Right. It's just finally becoming directed. And the Keytruda, that works on the CD1 receptor. Is that true or no? Am I getting that wrong?
That's pembrolizumab is the name it goes by, and also pembrolizumab, nivolumab, avelumab, durvalumab. There's a bunch that are out there. They all target that PD1, PD-L1 interaction. Right. Yes.
And anything with a MAB is a monoclonal antibody. That's
appropriate. Yeah.
Now they were doing monoclonal antibody stuff back in the 90s, correct?
Oh well, research-wise, I don't know.
That's what my friend. I thought that's what my friend.
Well, there have been other monoclonal antibodies that target growth factor receptors like EGFR receptors or HER2. Herceptin is a target. It's an antibody that targets. These are directly targeting immune system interaction.
Okay.
So yes, we've been doing antibody work for a long time.
What's exciting you now? What are you working on that excites you? You heard about that excites you? Where are we going here?
Oh, so multiple things excite me in this field of immunotherapy. We're working through our collaboration with a pharmaceutical company to try and make adoptive T-cell therapy available to all, because you need an FDA-approved lab to grow these T-cells unless you have a central place. And so we're part of a clinical trial that's looking at that, being able to achieve this ability to have one central lab and then be able to give this adoptive T-cell therapy to many different patients in many different locales. The second one is combinatorials, combinations of immunotherapeutics, whether they be checkpoint inhibitors or checkpoint agonists together. One of the most promising things that we found is a drug which is a inhibitor of a suppressive enzyme in the microenvironment, a drug called epacadostat. And that combined with PD-1 inhibitors has shown very significant early responses. And the caveat there is it has shown no increase in toxicities, no increase in side effects, really, from just receiving a single-agent PD-1 drug. And so that's a huge step forward. In fact, we're looking at not only doublets, but triplets of these drugs. And there are other antibodies. There are bispecific antibodies, which is an antibody. I call it a Yenta antibody. It's a matchmaker. It's an antibody that has two sides. So one side clamps onto the T cell, and one side is made to clamp onto the cancer cell. And it brings these two together and says, hey, you two should be together, but in a toxic relationship where the T cell then destroys the tumor.
How does the epacadostat, how does that work, the epacadostat?
The epacadostat is an inhibitor of an enzyme that converts tyrosine to kynurenine, and the kynurenine is immune suppressive. It suppresses the T cells in the environment. When you give epacadostat, that is an inhibitor of that enzyme, so it sort of disallows that immune suppression in the tumor microenvironment, in the area where the T cell has to come through to get to the tumor itself. And we've just presented very interesting phase 2 data, and the phase 3, the randomized trial of looking at epacadostat plus pembrolizumab versus just pembrolizumab alone has fully accrued, and we look forward to giving data there within the next couple of months.
Okay, so those are phase 2 trials are?
Phase 2 are trials where you found the correct dose of both drugs to have together or a drug to give, and you choose one type of cancer patient, so all melanoma, and you look at anywhere between 20 to 80 patients and try to find a response rate or benefit. And when that shows enough positivity, you move to a phase 3 trial. And a phase 3 trial looks at what the manipulation you're looking at versus a standard. So the phase 3 trial would be looking at the standard, which is a single agent PD-1, versus what we may feel could be better, which is the combination of a PD-1 and another drug. And if that shows a significant benefit in either response or survival, then that becomes a new standard. And that's what we're looking to do. And not just in melanoma. These trials are now going ahead in lung cancer, kidney cancer, and head and neck cancer, a multitude.
It's really very interesting stuff. I mean, colon cancer may have solid tumors may respond to this stuff, which would be crazy. The one thing
I forgot. We found a subset of colon cancers that respond to immunotherapy.
Yeah, I'd heard that.
And at a time.
Yeah, I had heard that. How do they determine that particular subset? Is that on a genomic testing or cell surface?
Yes, exactly. Yeah. Genomic testing.
Yeah. And one thing I want to get across to people, the checkpoint inhibitor, it's one thing we didn't explain. Explain how that works.
Well, a checkpoint is a point where in your immune interaction where you can either have a positive or a negative. And a checkpoint inhibitors at this point inhibit an inhibitory checkpoint. Let me explain that better. We have things in our T cells that are like, our T cell would be like a car, and we have brakes on that T cell, and we have a gas pedal on that T cell. And there are the PD-1, PD-L1 interaction is like hitting the brake on your T cell. And so a checkpoint inhibitor, that drug that we make like pembrolizumab or nivolumab, ensures that brake can never be fully engaged so that the T cell works. And we have things that are checkpoint agonists, and those target interactions on your T cell that work to stimulate the T cell.
Very good. Okay. I feel like I got my whole immune primer set. How about you, Bruce?
Yeah. So if I get diagnosed with a melanoma right now, and I say, wow, I've studied this, and I say, I want to get in on a phase 2 trial because I think those are the combinations I want. Where does or I guess a bigger question is, can somebody go out there and actually get old school treatment and not know about some of the things you're doing, and how much choice does someone have if they're educated on this? Because someone like Michelle, our producer, she's very educated. She might come in and say, I want to get in on those phase 2 drugs. Yeah. So what's the
she doesn't even have melanoma. She wants to be on a phase 2 trial.
That's true. I would say almost for everyone with any cancer, it's appropriate to see an oncologist, to ask for a second opinion at a center of excellence that relates to your tumor of choice. So, at the Angeles Clinic, we have expertise in melanoma and lung, colon cancer. But for example, if you had a rare leukemia, it wouldn't be the right place to come. We would see you and offer therapy, but ask for a second opinion from an expert in that field. And it's always within your right to do that. If there are places for melanoma, I would say you could reach out to the Melanoma Research Alliance, which has a website on its own. AIM at Melanoma is a patient-centered website which has a list of the centers of excellence. Your oncologist will be happy to refer you. Many oncologists who are in research are always available to ask a question or to connect with and say, where should I go near my house? Who is a person in my state? And everyone I've worked with has always been willing to email back and answer back. I think you have to be an advocate for yourself and form a team. And these days, they're virtual teams. You may want a specific surgical oncologist who is at one institution and a medical oncologist who's at another, and a expert to be part of your team who you see at times where there are decisions to be made. it's absolutely becoming, it takes a village, I guess is the best way to say it. And at multiple times, it may take one or different experts.
Yeah. I think that's an important point. Producer Michelle's got a question for you.
Hello. So back when my stepmother was diagnosed, we went to a symposium or two that was hosted by you and several other doctors and organizations, and you sort of characterized the period 5 or 6 years ago as the golden age of melanoma treatment because the vemurafenib, is that right? Am I remembering that right? And the ipilimumab,
yes.
Yervoy, and what's the other one? Yervoy and what's the other? Zelboraf, that's it, yeah. That those were sort of getting superb results, but today you guys aren't mentioning any of those drugs, and I'm just wondering if we've surpassed that now because the pembrolizumab is far surpassing what those did, or would people still be given those to deal with certain types of melanoma as well?
So I would say that we have not moved past those drugs, but we have found, for example, ipilimumab is a checkpoint inhibitor that inhibits CTLA-4. We have done randomized phase 3 trials that have shown that the PD-1 drugs work better initially than the CTLA-4 drugs. Mm-hmm. We are now doing trials where we combine both of those together to see if there's a subset of patients that benefit. In addition, Zelboraf and other BRAF targeted agents are being looked at in combination with other targeted agents and in combination with immunotherapeutics. So they haven't been left aside. They've found other partners to work with. They have found a specific place to be in, and they're all being utilized together. In fact, that time when you came and we talked about targeting a BRAF mutation.
Right, I was just going to ask you about that because she didn't have the BRAF mutation, or so it seemed when that drug didn't work.
Better explain what the BRAF mutation is.
That's a change in the in a chromosome in an area in the BRAF gene that leads to what we say constitutive activation. It leads to the cell being turned on and dividing without control.
Right.
And we have drugs. We have a way through a genetic test, a genomic test, to find out if you have it. About 8% of all solid tumors have it. About 50% of skin melanomas have it. And then through medications that are orally given, we have found that we can block that, and that causes regression in the tumors. And in fact, at this time when we're speaking, we're just a month or so away from the FDA approving this type of manipulation, not for melanoma, which was approved a long time ago, but now for lung cancer, because it is now a therapeutic for non-small cell lung cancer.
I think that they're finding novel approaches to that with prostate too. So it's becoming useful all over the place.
Absolutely.
Well, very interesting stuff. Bruce, any more questions?
Well, Michelle had one here. The September 2017 study, the Salk Institute identifying mechanisms by which cancer shuts down the immune system. Is that something you want to mention? Or?
Well, I think that's the future and a good point to sort of tie into a bow here. We're looking at predictive and prognostic markers for immunotherapeutics, which tell us which immune therapy to take off the shelf and use for patients based on taking a sample from the tumor or a sample from the blood and seeing which immune mechanisms the tumor is utilizing to evade destruction. So that's the first part. The second part is, yes, these drugs work, but at some point they may work for someone and stop working, or they may not work at all, and we're trying to figure out how that happens in order to try and avoid that, or to tell patients, before you come in and see me and I say, well, I have one thing in my toolbox. Now I can say, I have a multitude, and you may get a phenomenal benefit just from one of them. And you may need two of them, but those giving you two may come with increased risk of toxicity. So understanding those pathways, understanding how what immunotherapy to choose is appropriate for hitting it out of the park the first time and avoiding significant toxicity and avoiding giving medications that are not useful or may come with increased morbidity.
Well, Dr. Hamid, thank you so much. Again, the website is theangelusclinic.org. It's over there between Bundy and Barrington on Wilshire, right? I looked it up while we were chatting.
That's right.
And it's here in Los Angeles. I, of course, if you're outside the Los Angeles area, I'm sure if you contact them, they can tell you whether or not it'd be appropriate to make the trip out here, or if there are similar centers of excellence near you. Please do check it out. You can also follow them at Angelus Clinic. And Dr. Omid Hamid, appreciate it so much you joining us. And for me, it's almost impossible as a primary care person to keep up on this stuff because it's going so fast. Yep. And as I said, I sit through a lot of bench research on the prostate cancer side, so I can kind of intuit where it's going in other areas of oncology. But oncology is in its golden age right now, and it's congratulations. It's really very exciting work.
I want to thank you all for the opportunity and the ability to talk on something that I can talk on forever.
Thank you. Fascinating.
Great.
Well, thank you so much. And we're going to take a little break. We'll be right back. All right, it is fall and your immune system is about to get tested, everybody. Not only does the changing weather mark the start of cold and flu season, it's also back to school time when kids become walking petri dishes. While catching something may be inevitable, there is no excuse for letting yourself get dehydrated in the process. So when you're wiped out with cold or flu, the first piece of advice always to drink plenty of fluids, but we seem to forget that. Now, once you've started feeling dehydrated, it's already too late for water or sports drinks. Rapid rehydration requires the proper balance of sodium, glucose, and water, and nothing gives this like Hydrolyte. Hydrolyte's formulation is based on established, proven science, and it is the simply best rehydration product I've found in this country. Hydrolyte comes in great flavors, orange, berry, lemonade, and it's available in a pre-mixed drink, a powder, or what I prefer, those effervescence tablets. You just drop in a glass of water or a bottle of water, off you go. It's like your own portable IV, but you can do it enterally. Compared to sports drinks, Hydrolyte delivers up to 4 times the electrolytes with 75% less sugar. Hydrolyte solutions are appropriate for all ages, and each bottle or package includes easy-to-use, easy-to-follow instructions. You can find Hydrolyte at Rite Aid or online at Amazon.com. And for a limited time, our listeners can save 30% on Hydrolyte. Just click the banner on our site, drdrew.com, 30% off. Great deal. Do it. Well, one of the great parts about working in recovery is seeing former patients successfully move on. And I've had patients that have come up to me years later and shake my hand and say, you know what, sometimes people are kicked out of treatment. And many of these folks move on to become mental health professionals themselves. And, of course, the field of psychology is vast. The need for competent practitioners is huge. If you're considering this rewarding career, I urge you to consider the California School of Professional Psychology at Alliant University. Now, I've known them for a long time at Alliant University. I've spoken at their past events. It was founded in 1969. It's boasts an alumni network of nearly 50,000 people worldwide. And Alliant has fostered many of today's mental health pioneers, authors, and advocates. CSPP at Alliant University hosts both on-ground and online programs in business psychology, marriage and family therapy, clinical counseling. They also offer APA-accredited doctoral programs in clinical psychology that can allow for specialization in child psychology, clinical forensic psychology, and integrated psychology. And the faculty is crazy. It's made up of leaders and historical figures like Abraham Maslow, Carl Rogers, Viktor Frankl, some of the true fathers of modern psychology. For more information, and I worked alongside of these students as well, by the way, in the clinical setting, as well as having lectured at the institution. So for more on the California School of Professional Psychology, CSPP, at Alliant, click the Alliant banner on our website or visit Alliant, ALLIANT.edu, alliant.edu. And we are back, and it was fascinating, all this stuff. I love talking to these guys. Let's do a quickly go through some emails here. Okay. This is from Carlos. Heard you mention HPV vaccine. I'm a 51-year-old male. My dad was diagnosed with anal cancer. Is the HPV vaccine appropriate for me? In other words,
51-year-old male. Yeah.
The dad has anal cancer, right. So his appropriate assumption is that it's related to HPV. Very interesting. But I don't think it's not
because he's already exposed. Once you incorporate it into your,
but he's not going to get it from his dad. You know what I mean?
Right. But I think he's wondering, or is he thinking he might be at increased risk?
He thinks he himself might have gotten it like from a towel or something. it's not contagious.
But a lot of people. So I think the reason you want to do it early on is once you get a virus, you might get rid of it, but it can get into your own genome, right? It can attach,
and that's how
and then it's too late for the vaccine.
That's how it does its cancer-causing stuff. So although sometimes maybe you can jack up the immune system to I don't know. I've heard people talk about whether or not the vaccine is appropriate to.
But have you seen a study of adults?
Well, I've heard people talk about using it as adjunctive treatment in these HPV-related cancers. No benefits that I've heard of yet.
Right.
But if you're a young male and you haven't had the vaccine, you should get it anyway. So
if you're a parent with a kid, don't be
silly.
Misled by the insanity of don't getting vaccine.
Yeah, get the HPV vaccine. Dad got prostate cancer. He's 30 years old. He got it when he was 57. Now in remission. Nice. Started balding in my 20s, and I'm almost bald now. I've read that that's a sign, high chance of prostate cancer and heart disease. Balding? Well, I guess you have high levels of testosterone. And maybe, but the prostate cancer risk, you're already at high risk for prostate cancer, my friend. Sorry about that. With a dad that is diagnosed young, you need to start getting regular checks at age 40. You're 30 now.
Right.
At 40, you begin the digital rectal exams and the PSA. Also, there is some evidence that prostate cancer is associated with other genetic or predisposing genetic issues for cancer. I have Lynch syndrome.
Right.
You can get tested by color.com. We interviewed those color guys. It's $200, and you spit in a cup, and you can find out if you have any of these genes, and it will change how the insurance companies cover your screening. You get more frequent colonoscopies, more frequent upper endoscopies with some of them, and they might even change the way they screen the prostate cancer.
Good counseling and advice from those guys.
They really do. Ooh, here's some about Lynch syndrome. Just listened to September episode. Thought I heard Dr. Drew say he was a Lynch syndrome, MSH6. That's true. I worked as a genetic counselor. I was wondering if I heard this correctly. If so, it'd be awesome if Drew could raise awareness of Lynch syndrome. It's estimated that less than 5% of people with Lynch know they have it. I think that's true because nobody gets tested. I didn't know until recently. And that it, let's see. It causes many preventable cancers like colon cancer, but more people are aware of the BRCA1, the BRCA2, right, with breast cancer. I've often wished there was a celebrity out there who would raise awareness as Angelina Jolie did. I thought I heard Sharon Osbourne had Lynch. I don't know that's true, but Sharon did have colon cancer, so that wouldn't be surprising. Yes, we were talking about it. I've got it. My sons have it, and because we got my sons tested as well, they're going to be in screening at age 25.
Now, I was looking at some blogs and websites, and there's some controversy as to whether you should be
tested.
Yes, and what to do, and the fact that there's misinformation and it's causing overreaction in some people. So I think that goes to.
It's like any test. You better know why you're testing, why you're doing it. And so the question is, should everybody be tested for their potential screens? And then it gets a little dicier.
Yes.
It gets a little dicier. But if somebody has colon cancer, prostate cancer in their family, and
absolutely.
Then it makes
sense.
But
what about physician education? Many physicians out there.
Never heard of it.
Right.
Never heard of it. And certainly don't know about color and the genetic screening and stuff. I have begun to recommend it for highly motivated middle-aged patients or even middle or older patients that have significant family histories.
Right.
I've begun to do it.
Absolutely. There's so many people, if you ask them, they have a primary relative with one of these cancers, and it would be life-saving for them to be tested because a significant number will be at risk.
And they've loosened the screening for colon cancer every 10 years in non-risk populations, but non-risk populations are people that had essentially have had 2 consecutive negative colonoscopies, but you could have Lynch syndrome and pop up with a tumor in 2 years.
Right.
So it really does change things a bit. It certainly changed my approach to myself and my family. So, I'm a big fan. What else did you learn from these blog sites?
That was about
that it's controversial.
Yeah, it seems like there needs to be. I think what they're saying to you, if somebody could, there's not general information that even physicians can clarify for people. So it seems like there's a place right now in medicine, just like talking about immunotherapies for cancer, but physicians almost need to go back. Everybody needs to go back and have mandatory. These are things you need to learn that have changed. Because
since you were in medical school.
Since we went to medical school.
It just seems to me if you're diligent in keeping up and talking to your peers, you'll kind of get it.
Right.
It gets into your...
I tend to get a little bit out there, but all the emergency medicine physicians, and I think sometimes there are people that have interaction with the public that otherwise won't see physicians, and it's hard to keep up on a lot of this, which might seem ephemeral to certain practitioners, if you know.
I know what you mean. I get it. Here's somebody who wants to show support to the You Live podcast. Loveline was very valuable, helpful show to a lot of people, and as a listener of Loveline, I was surprised to see it end. I wanted to show you my support of You Live because without the mention of my support, you may not know you have it. This is one of my rare positive emails. I'm sure many others feel the same way, but simply may not have reached out to communicate it. Peace and love, You Live. Peace and love, Mike. Peace and love. From
Ringo. Ringo's
friend. Let's see. Okay, this is interesting. The boyfriend recently tested positive for chlamydia. I tested negative. Last time we had sex was August 18th. He is adamant that he has not slept with anyone since we last slept together. Is it possible that he had a false positive or I have a false negative? Both possible, I will say. I keep searching for reasons why he could have tested positive. I didn't. I'm almost certain he cheated on me within the last 3 weeks. Well, if that's so, I'm amazed the way people, when they cheat and don't admit it, and it's important and it's medically relevant and they're being called out and they still refuse to cop to it. I don't get that. Can you help me understand if there's another possibility for him having it? So there's 3 possibilities. He cheated. He has it. There's 6 possibilities. He's cheated. He's positive. He's got it. He's cheated. He's positive. He doesn't have it.
Right.
He's cheated. He's positive. You're negative, but you're actually positive. That's one possibility. A possibility is he didn't cheat. Didn't cheat. He's positive and doesn't have it. I suppose you could both have it by some means. That's possible. I don't know where it would have gotten in there without somebody having cheated. The point is they could both be false.
Depends how she was tested, too.
Either could be false.
She could have had it previously dormant.
Yep, that's right.
He got it
from her.
She then tested a different way and was negative.
That's right.
But I hate it, especially the emergency department, when someone has a positive STI test, and then it becomes the test rather than the honesty.
Well, here's what I always do. I always treat. I go, look, take your Zithromax.
No, but I'm saying when people when the relationship is such that it's the test that
I know, and that's the other thing I say. I counsel them not to make their determination about what's going on based on this test.
Oh yes,
it's leading me as the physician to treat you to make sure you're safe. What happened here? This test does not determine that.
Right.
And you better somebody better get honest or not, and then go about your life.
Right.
So it's kind of an interesting question.
Everyone gets treated in the ER.
All right, are we running out of time here, buddy? Susan, producer Susan, is that okay?
But you can mention you're still doing Loveline with Adam, basically. The people
I'm still doing the Adam and Dr. Drew show. You get it at drdrew.com, and it's me and Adam, and you can call in. It's not a very Loveline-y show, and Adam and his thoughts
rants
on life and rants and things, mostly what we're talking about. And but we do a This Life You Live podcast with Mike Catherwood that is Loveline-y.
Yeah.
And usually we do that on Facebook Live and other things, so you can be a part of that one. So look out for that. # You Live. If you Google that, you'll figure out where we are with that particular podcast. Or what else, Susan? Howard Vortex. Oh, also the Howard Vortex. That's right. Where me and Ami Horowitz, which I'm about to do now, interview some of the whack packers and the people whack pack adjacent. If you didn't know already, we have a YouTube channel. Go to YouTube/DRDREW, YouTube/Dr. Drew. See the live videos and podcasts there. Subscribe, and you'll get it when we go live. Find the channel, get the videos today, but also be sure to download the podcast and listen to them as well. We appreciate your listenership. We appreciate your support. And we'll keep this thing going as long as you want us to. All right, Bruce, thank you as always. Appreciate it. It's very interesting today, and we'll see you next time.
Remember, you can find all these podcasts at drdrew.com. The Dr. Drew podcast, the This Life podcast with Dr. Drew and Bob Forrest, and the Adam and Drew podcast, which is available 5 days a week. Find them all on iTunes and rate us 5 stars. Subscribe and get it first. And if you're really happy, click on the Amazon banner at drdrew.com to help support the show. We'll thank you for it. If you join the email list via drdrew.com/contact, we'll send you a weekly infusion newsletter with Dr. Drew's news. We're so grateful when you get in touch. We read all your emails and we'll bring you the subject matter you want to hear about.
Hey, Dr. Drew here, and this is just a reminder that the discussions here are not a substitute for medical care or medical evaluation. This is purely for entertainment and education. We hope you learned something. but see your doctor, get proper medical care.